Thank you, Josh. My name is Paul Lefebvre. I am a lead claims professional and risk advisor for Preferred Physicians Medical. And according to Tony's chart, unless Yvonne is a member of Congress, I'm the least trustworthy person on this panel. So I'm going to try to share some information and cautionary tales today. We are Preferred Physicians Medical is a anesthesia-specific professional liability carrier. We insure anesthesia professionals and practices all across the country. I do not have any conflicts of interest to disclose. It's a privilege to be invited to speak on this panel, just a few miles away from where the APSF was founded almost 40 years ago. Around that time, new monitoring technologies like pulse ox and capnography were introduced. The closed claim study was launched. Simulation-based training was introduced. The ASA adopted national standards for basic monitoring. You might consider our company a byproduct of the founding of the APSF and the advancements that followed. In 1987, PPM was founded by an anesthesiologist who, like the folks at Harvard and Crico, anticipated that intraoperative complications, often attributed to anesthesia, would be far less likely to occur. So he founded our company, and the basic monitoring standards are actually part of our policy, and they have been since our inception. He and the other pioneers from the APSF were right. Safer medicine did lead to fewer claims and lawsuits, and liability insurance premiums for anesthesia professionals decreased significantly. Throughout the next few decades, numerous initiatives spearheaded by the APSF advanced patient safety and helped prevent avoidable harm. We've seen this in our historical loss data. Our claims history also reflects that medication error prevention has proven to be one of the most challenging problems the anesthesia community has endeavored to solve. In a few minutes, I'll share some of our loss data and patient safety strategies to prevent medication errors. But first, I want to start with a case study. This was a file I handled a few years ago to highlight a very concerning loss trend we've recently identified involving a particular type of medication error. This won't be the first time that we've heard about these. So this case involved a 60-year-old male who presented to a critical access hospital, 25 beds, for left hip arthroplasty. The anesthesia plan was for a spinal. The patient was transferred from the pre-op area to the operating room where the spinal was performed. Our insured, the anesthesiologist, removed what she believed to be mepivacaine from the tray in her anesthesia cart. An important detail is that this group covered 2 hospitals. The anesthesiologist was typically at the other facility, and she was assigned to this one on the schedule to cover for a colleague who was on vacation. So it was a little bit of an unfamiliar environment. The health system had also just contracted with a new vendor for procuring medications. And this was her second case of the day, but when she had her first case, she noticed that there used to be a red red cap on the TXA and a blue on the local, but that they were both blue. So she thought to herself, oh, I need to be careful. And she went ahead and handled the first case for the day. This was the second case. So due to the patient's body habitus, it was a little unusual and had some trouble placing the block initially. So when the patient reported some lower back pain and itching on his backside, she elected to convert the case to general anesthesia, assuming that this was just a failed block. Shortly after surgery start time, the anesthesiologist and surgeon observed some clonic movements. I can only imagine the sinking feeling that she felt in the pit of her stomach as it dawned on her that maybe she'd grabbed the wrong vial with the blue lid. She went over to check the sharp spin and realized that she'd discarded the TXA after administering the spinal. She contacted her partner, one of the heads of the group, to let him know about what had just transpired, and he immediately started looking up interventions, an appropriate way to manage the complication. And then he got in his car and headed over to this facility to assist. They performed a CSF lavage. They drained off 30 cc's of cerebral spinal fluid. And as they were replacing it with sterile saline, they got about between 5 and 10 milliliters, and the patient started having some movement again. So they stopped and waited until they'd be able to transfer the patient to the ICU. He remained sedated and was transferred to a higher acuity hospital a few days later. Now, after the patient had left the OR to go to the ICU at the first facility, that's when our insured contacted our office. One of the hardest phone calls, part of our job. is oftentimes we talk to anesthesia professionals on the hardest days of their job, and this was certainly one of mine. She was devastated. She's a terrific clinician. She was a leader in the group. She was kind of their patient safety advocate. When we'd done risk management programs and things like that, it was clear that she was a leader, and it was tragic that this was happening to her as well. So that was a tough call, but she had some questions about documentation. She had some questions about conversation. How do I disclose this? Can I go out and talk to the patient's wife? And of course, this was a situation where it was a clear error. It was confirmed. There wasn't any investigation that needed to take place. So I obviously encouraged her to do what was right, what was human under the circumstances, and go out and apologize and explain what had transpired. This is one of 38 states that has what we call apology laws or apology protections, protecting benevolent gestures, sympathetic gestures from being discoverable during the course of litigation. But in the other states that don't have those, we're just going to offer our policyholders the same advice under the circumstances. I'm not aware of us ever having a case that hinged on whether or not the anesthesiologist or the CRNA or the AAC went out and apologized and conveyed their sympathy, whether it's a known risk and complication or whether it's a clear error. And Tony, it's hard to define error, I suppose, in the legal context. We look at these through the lens of whether or not there was a departure from the standard of care. Best I could probably do is that this is a preventable harm that is indefensible from a standard of care standpoint. And when the documentation question came up, she asked about also, is it okay to put error in the record? And of course, we didn't need to get a thesaurus out. It wasn't going to keep us out of litigation if that was what the patient was going to pursue, or in the interest of resolving it once we knew the nature and extent of the patient's injury. So obviously I encouraged her to do that as well, which she did. The patient remained sedated. He was transferred to the other facility. He emerged and was extubated on post-op day 4. This is by far the biggest outlier of all these cases that we have. This patient went on to make a remarkable recovery. He was discharged on post-op day 8. This was during COVID. So instead of sending him to a rehabilitation hospital, he did his PT. He treated with a neurologist, treated with a rehab medicine specialist from home. Over the course of the next 6 to 8 weeks, he really made what the neurologist described as a remarkable recovery. His biggest injury was some pain in a cervical pain, and that was likely from seizures or positioning when he was in the intensive care unit. So notwithstanding his outcome, obviously, the patient and his wife filed a lawsuit against the anesthesiologist, the anesthesia group, and the facilities. We mediated this case. This was within 9 months of the event transpiring. So this was a case that we knew we should resolve quickly, get together with the parties, and we did that immediately after the case was filed, actually. And it settled on behalf of the anesthesiologist, the group, and the facility for within our policy limits, and the hospital contributed 20%. So these are a few remedial measures that were implemented in the wake of this. They got together, they did peer review, quality review, and these were some of the solutions that they came up with. It was that local anesthetics used for spinal should be checked by a second person prior to administration. TXA should not be stored in close proximity to local anesthetics. The anesthesia group, and this wasn't our first TXA bupivacaine mix-up case. We encourage them to also coordinate with pharmacy, and I'll get to this in a little while, but about having TXA prepared in pre-filled bags. And I'd also mention that on the second day after this event happened, the anesthesiologist kept in touch with the spouse, and they spoke often in the immediate recovery period. And she mentioned that she hoped that someday that the story could be told as well, so that to avoid this type of harm happening to somebody else. So I'm happy that we're able to do that today. So here's a few other examples of medication error cases that we've seen. Overdoses, whether that's due to wrong dosages that are being administered in the facilities, or I guess overdose isn't the correct word as far as some of the opioid-induced respiratory depression, but we've seen some of those cases certainly over the years. Thanks to the work of people like Yvonne and organizations like the APSF, we've seen fewer of the opioid-induced respiratory depression cases at home, but there's certainly still work to do, and one is too many. Medication vial mix-ups continue to be our largest area of exposure. Here's just a few examples. We did have a neostigmine, neosynephrine mix-up as well recently, and my colleague actually had a call yesterday about another medication error that came in. On the also known drug allergies, sometimes that's attributed to issues navigating the EMR, workflow. There was one instance that came to mind as Dr. Vincent was talking that we had a insured report a sentinel event at an ambulatory surgery center involving loss of an airway. And 2 days later, he called back and said that it was a Friday morning case and the patient had a known allergy to a local anesthetic, and he overlooked it in the record. And there was a component, I think, of getting back to work, and that was a tragic outcome for the second patient as well. So I think that's an example of facilities also maybe getting together with the clinicians that are there to support them and make sure that they have the resources they need before they return to work. Medication, so here are some common causes and allegations, and I stress allegations. These are the ways that cases are presented or prosecuted against our insured. So obviously a momentary lapse in concentration or situational awareness, that's more an allegation than some of the investigations that would reveal. So systems issues continue to be one of the most prevalent causes, and we've talked about lots of these this morning. I wanted to share some of our company's loss data. The 236 number I thought was pretty high until this morning when I saw the poll. So either we insure the luckiest 6,500 anesthesia professionals in the history of the world, or these are being underreported to us. So that's in the last 37 years, we've had 236 medication error adverse events reported to us. 79 resulted in a claim or lawsuit, and indemnity paid has exceeded $17 million. Defense costs are approaching $4 million. We have moderate severity files, 21 of those for just over $100,000 in what we call indemnity, which would be the settlement or judgment if it went to trial, which obviously for the reasons I mentioned, these do not. The most concerning trend that we've identified is these cases that are resolving for significant amount of money. And I don't use that in the context of narrowing things down or reducing things to $2. What we would call claims severity is a reflection of the harm that the patients are experiencing. And that is what brings us to the concerning trend and the particular type of administration error. So we now have 9 tranexamic TXA mix-ups that have been reported to our company. When I got together and had the opportunity to write an article with Dr. Ribello and Dr. Jew and Angie, Lindsay, and Tricia Meyer, I think we were at 5 or 6 at that time. So we've had 3 over this summer, and I most recently took a similar call 3 weeks ago. So these are continuing to occur, and in fact are occurring more frequently than they did in the past. So those 4 cases have settled for over $6 million, which represents 35% of all of our company's historical medication error losses. And that does not include the 5 that have been reported and not yet turned into claims or resolved. So to illustrate some of this, I just wanted to break down, this is the last 3 decades as far as our medication error. This is the indemnity payments. So again, to reflect the frequency and severity of the claims that we're seeing. And you can already see that we're exceeding the prior 2 decades. And this does not include those cases that have not been resolved yet. So we do what's called reserving, where we set aside money in anticipation of resolving those claims in the future. And when we add that on, this is what we're looking at for this decade. And this is almost entirely driven by the tranexamic acid bupivacaine mix-up, wrong route, medication errors. So we will be about 3-fold what we were from 2005 to 2014, we anticipate. Dr. Ward, don't throw tomatoes at me. I'm sorry about the read the label carefully. The ISMP's hierarchy for effectiveness of risk reduction strategies is an effective lens to use some of these through. And That while education and warnings are the least productive and the lowest leverage, we've got lots of policyholders around the country that when we go around and we share these presentations and slides with them, they do an eye roll when we talk about barcode scanners and things like that, because they're in critical access hospitals or ambulatory surgery centers or doing office-based anesthesia. And those simply aren't things that are made available at those facilities. So I hope that we're working towards that. The technology, culture, and collaboration strategies, these are all born out of the last Stoelting conference on this topic. There's been some wonderful technological advances that have and will drive change in the right direction. And embracing a culture of safety, patient safety is obviously important as well. Encourage the reporting of near misses at your facilities. If the technology you're asked to use doesn't fit workflow needs and patient safety, let the administration or department heads know. Make sure everybody is kept in the loop when drug shortages arise or when the facility changes drug vendors. If vials aren't stocked in the right place, make sure it's brought to the attention of the tech or the responsible department. And lastly, collaborate with pharmacy if that's an option at your facility, or get ready to administer products that can be used in the OR. If practical, ask them to do pre-filled syringes and reconstitute medications. This is really the key intervention for these particular medication errors. This is the high leverage risk reduction strategy the anesthesia community needs to get behind for the TXA bupivacaine mix-ups. I appreciate that my experience and perspective is different from the clinicians in this room. Yesterday, I had an opportunity to tour the Ether Dome. That was if I can count that as an operating room, that was the third operating room I've ever been in. So my experience is obviously very different from everybody here. So I'm always very mindful of advocating for a particular action at the exclusion of others, since I can't fully appreciate how implementation will work in your facilities and what the collateral consequences or events that stem from it could be. That's why I was elated when we were working on the article and Dr. Ribello and Dr. Jew and Dr. Meyer all we got towards the end, and I can't remember who it was, but the email went through. It said, "No, we got to get behind ready to administer products." We've tried some of the other things. These medication errors, this particular one cannot continue to occur. We have one solution that would solve the problem. So, as stated in the article's conclusion, the costs and resources required to bring about this change are inconsequential when you measure them against the harm that the errors occur or that the errors cause. The time to act is now. Thank you.